Hi, I'm Wendy Chung. I'm going to be talking to you about gene therapy and trying to give you part of a two-part discussion, followed by Tim Yu talking about one particular type of treatment. So, this I want to give you an overview, and I know this is a little bit overwhelming. It's not meant for you to be able to read everything that's going on, but I did want to show you the gene therapy space. For the point that I want to make here is how active it is. This is not something that's, I think, 20 years off in terms of doing this. This is here and now, but it is definitely evolving. So as we think about this, the circles, if you will, this is the finish line we're trying to get to in terms of things that are approved, that are effective, that are available with a prescription. This center, this bullseye is where we're going. Each of these rings that are coming out of here are the steps that you need to get to, the different stages, the hurdles to be able to get over the finish line here. And as you can see, we have a lot more things. The circle is bigger at the edges when we think about the beginning of clinical trials. So we call these phase 1 or 2 trials, things that are out here at the periphery. And then each of these are steps as we get closer and closer to the finish line. So the point in terms of thinking about for the community for Simon Searchlight is these stars that you're seeing on the edge, these stars over here, are the ones that represent neurogenetic conditions. So you'll see this full space in terms of everything. These are all genetic conditions or mostly genetic conditions. But the ones are the stars of the areas that are really of greatest interest to us. And in a good way, it's not just one. There are actually many conditions that are slowly but surely marching forward. And I'm going to talk about the sort of science behind that and hopefully help you to be an educated consumer, really an educated participant in research. And I'm starting this now because I do think there are going to be opportunities to participate in these really important research studies. And I want you to be able to know how to think about them and to make good decisions for you and your family. Okay, what am I talking about? What am I not talking about? So let me be very clear. I am not talking about doing any sort of gene editing or gene manipulation that's going to change the human race and mankind for generations and generations. So I am not talking about what we call germline gene therapy, where we're trying to change eventually the genes of humanity and have them go on for generations. No, 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 that's not what we're doing. We are doing what we call somatic gene therapy. So by that I mean we're doing it in the cells in the body, not the sperm cells, not the egg cells, not the next generation, but we're doing it to make the present bodies better within that. And that's really important. We're not trying to do any sort of enhancements and make Superman or anything like that. We're trying to really help folks that need help to be able to live healthier, better lives. Okay, so when we start talking about this, there are many ways of being able to get genetic information into cells, into the body. And so I'm going to go through a few of these different ways. Um, some of you may know, and this is really something that we learned through COVID. It's what I call one of the COVID bits of lemonade that we got after all those lemons of that virus. One of the ones is that some of you, like me, I'll put myself out there, had a vaccine that was made with really technology that had been built and worked on for over 2 decades, over 20 years in terms of understanding how to be able to package DNA or nucleic acids into little lipid particles that you could then put into the body and would be taken in by cells. And that was for me when I got my vaccine, essentially how I got the vaccine and got little bits of that coronavirus into my body so that my body could mount an immune response. Well, there are other ways to use that same technology. So we have DNA that can be wrapped into fat like liposomes, in other words, these lipid particles. You can put it in there, and those particles can basically then come into cells and be able to deliver that DNA into cells. So that's one way of delivering the information we need into cells. Another way that we can do it is that we can package that into a virus that's been very carefully engineered. So, unlike the coronavirus, it doesn't break free and start infecting people, it doesn't travel around the world. It's been handicapped so that it can't do that. It stays within the one body of the person that you administer it to, you inject it to. But within that, it can be able to deliver a cargo, deliver a load, deliver a package of genetic material. And we can make these and design these very, very carefully so that we are doing this specifically for the gene of interest for someone who has a genetic condition where we might need to deliver a gene. And I'll get into some more specifics there. In some cases, we do that because we do it in the person. So if we want to be able to deliver it to lung cells or muscle cells or liver cells or brain cells, we do the injection directly into the person. In some cases, we do an intravenous injection. So we get a vein and we get it into the body that way. In some cases, we need to do an injection directly into the organ that's important. And so when we think about brain conditions, in theory, that might even be an injection directly into the brain or an injection into the right by the spinal cord, because we know that the fluid that goes around the spinal cord also comes up around the brain. And so it's a way to be able to get access to the brain through a way that we can get into the body. In some cases, we actually test or we treat the cells outside of the body. So rather than doing an injection into the body with this gene therapy, we can take cells out of the body. We can treat the cells there. We can find the cells that correctly absorbed the material and then put those cells back into the body. There are certain conditions, certain disorders that respond better to that. So, for instance, it's not hard for me to take blood out of your body or a bone marrow sample out of the body. And with that, so for individuals who have certain blood conditions or certain immune conditions, we can do that type of manipulation. We can take those cells out of the body. We can be able to make some changes, and then we can put a person's own cells, but now genetically engineered, back into their body. For brain conditions, I don't think that's going to be the likely way most of those will be treated. Although we do know that some cells from the blood, believe it or not, can get into the brain and do, in some cases, really important things. Most of the conditions in Simon's Searchlight, I don't think are going to be treated that way, but it is formally a possibility. Okay, so what are the different things that we're trying to do as we think about these genetically based therapies? So there are a few different ways in which these genetic variations can cause the problems. So we've got a normal gene, and for the conditions in Simon's Searchlight, we've got usually one gene, occasionally more than one gene, but usually one gene that has a problem. It has a variation, it has a change in it, a difference in it that makes it either, this is important, either produce no protein or none of that gene product, so it didn't show up to work. And that's a problem, not having enough. Or in certain cases, it does produce a protein, but that protein is not right. And in fact, in some cases, that protein not being right actually gums up the work. It causes a problem. And we'd actually like to be able to get rid of that protein. So I'm going to come back to that again in the future. For your particular condition, it's important to understand, based on the strategy we'll use, whether for your condition there's no protein produced, or if it looks like there's an abnormal protein produced. There's kind of a bifurcation or a fork in the road, as I'll show you in the strategies we take, depending on which one of those two it is. Okay, so I'm going to talk to you about 4 different general strategies. I'm going to break these into pieces, but again, it depends on that fork in the road to a certain extent, which way we go in terms of these different strategies. Okay, so in certain cases, we have a gene and it's, again, not doing its job. It hasn't shown up. It's not producing a protein. And so we need to be able to give that protein to the person. In some cases, people have none of that protein or close to none of that protein, in which case we have to give them back that protein entirely. If they're missing it entirely, we have to give it back to them. In some cases, for many of the Simon's Searchlight conditions, the person is making some of the protein, but it's making about 50%. And so we need to be able to get in about 50% of the protein. That could, in some cases, be because we literally give it back. We bring one of those systems to be able to bring in that gene and bring in that protein, and we try and replace what's missing. And so that's one way that we think of doing this. In some cases, and this is a little bit different, we can think about not even the gene of interest, but there might be some other way of compensating for that gene that's missing and add a completely different gene, but that might downstream be able to take over. If there's some other way, some other step in the process that we can tweak to be able to make things better, it doesn't have to be the exact gene that has the problem, good, but it could be something else downstream. And again, we think of that as an addition, not a replacement because it wasn't missing in the first place, but kind of adding something else in. But again, we're adding something as we think about that. Now, in other cases, as I said, this is kind of before I was talking about the right side, now I'm talking about the left side. So now if you have a gene that's not doing its job and it's wreaking havoc, it's doing something it shouldn't be doing, we want to take that out of the body. We need to get rid of it before it causes harm. So as we think about that, that's kind of fundamentally a different strategy. We want to be able to silence it. We want it to be able to go in the corner. We want it to go out of the body. We want to be able to knock it down. We want to push it aside. We want to take the one copy of that gene and quarantine it, is a way that I think of it. Now, this is tricky sometimes because for the Simon Searchlight genes that are in this situation, we usually have two copies of the gene, one of which we need to silence. The other one, though, we need it to do its job. And so as we think about this, we want to very selectively take down the copy of the gene that's causing the problem. We want to selectively take out, knock down, other terms that we use for this, but be able to put that one aside to quarantine it. Different strategies, again, to be able to do that. So important to know which your gene fits into. Now, one size fits all in terms of a solution, and it's kind of the holy grail of what we're all looking for, is being able to actually do a gene correction. And this would theoretically work whether you've got either of those two forks in the road. So either if you're missing something, being able to do the gene editing, the gene correction in the DNA itself, directly in the cell, in the nucleus, in your DNA, fix it. Be able to edit it, be able to, like surgical scissors, snip it out, go to the right place, snip it out, sew in the right sequence, but basically fundamentally fix the DNA in the cells. As you can understand from what I'm saying, that's the holy grail, right? That would be the nice thing to be able to just take care of business, do it in your own body, not have to add anything exogenously, just do that editing that's there. That absolutely is where we're trying to go. There's some challenges in terms of getting there. We don't have yet the right kind of scissors to be able to go into every single different type of genetic change yet. We're getting better. Some brilliant people working to give these tools to get it better. We also have some issues I'll get into in terms of precision. So precision in terms of going to exactly the right place, not going to the wrong place, and making sure that we do the editing throughout the cells. Okay, so there have been some remarkable discoveries, and in fact, the Nobel Prize has been awarded for this CRISPR-Cas9 system, which is this way of being able to do gene editing. We do have ways of being able to do it in a focused way, so in a precise way to go to exactly the right place. This is something I will tell you we do all the time. We do it in my lab every day, but not in people. We do it in cells. We do it in Petri dishes. So we try out the technologies, we make sure they work, but we're doing this, like I said, in a controlled environment where lives aren't at stake because we still need to improve some of these technologies. And like I said, a lot of people doing a lot of good work to perfect this, but we're not there yet. In the meantime, we do have other ways of delivering, like I said, when we need to give back a gene that's missing or be able to compensate. And there are a couple different delivery systems to this. So let me just explain this so you'll understand what some of the challenges can be. So one is to use an adeno-associated virus. Adenovirus is the common cold. And so this is a virus that's associated with the common cold. We've co-opted it, we've gutted it, we've made it so that it won't give you the cold anymore. And we can package in, instead of the usual genes in that adeno-associated virus, we can package in genes that we want to deliver. So a gene that might be missing to be able to give back to people. This actually works really nicely. People have figured out ways of being able to get that adeno-associated virus attracted to very specific cell types in the body. They can make it hone into the brain, for instance. And so this is something that's much more effective than it was even a decade ago. In doing this, as we think about it, there are ways because of this, what we call tropism or this sort of magnetism to get it in. In some cases, we can actually give a peripheral IV infusion into a vein in your arm, for instance, and even in some cases have it go to brain cells. It's sort of magnetic in that way in terms of honing in where it needs to. So, a lot of advances in terms of getting it where it needs to go. On the other hand, I will say there are limited sizes of genes that can fit into this adeno-associated virus capsid, is what we call it. So it does have a limitation in terms of what I call the payload, how much of a cargo it can take. Can't take gigantic genes, but it can take many genes. And so people are doing various tricks to make mini genes or be able to think about how to increase the size of the payload, but there are some practical limitations and it's not one size fits all. As I said, another way of doing this is to use these lipid particles, these liposomes, to be able to package things. In some ways, that has some greater flexibility and some other advantages. And I forgot to mention this, but the adeno-associated virus can have disadvantages that if you've seen that virus before, so if you've had the cold, which many of us have, but if you've seen that exact virus before, your body might have an immune response and you might recognize it, and then your immune system would try and fight it, get it away, like you're trying to fight a cold. And we wouldn't want it to fight away something we were trying to deliver. The liposomes don't have those same problems, and so there may be some advantages in certain cases to be able to use that as a delivery system. So, within this, in terms of the clinical trials that you've heard about for gene therapy, the reason why that outer ring was so big and has so many different things, and that teeny tiny circle in the middle, that bullseye, was so small is because we have many things that we have to think about. Number one, we want to make sure what we're doing is safe. To me, that's number one, two, and three in terms of thinking about this. Of course, we also want to make sure it's effective. So as we're doing that, we have to figure out the safety things. Can it cause liver problems? Can it cause immune problems? We have to figure out the right dose. Sometimes, as we're worried about safety, we start out a lower dose to make sure things are safe, but maybe we don't give enough. And so we have to figure out increasing doses and we have to get it just right. It's like, the three bears: can't be too hot, can't be too cold, got to be just right. As we think about this, we also have to be careful in terms of some things we might not have expected to happen. Whether or not, like I said, it might actually go into cells, even though it's selected for tropism to go to certain cells. What happens if it gets in other cells? Will it do any damage? Will it do any problems? And so, as we do this, we oftentimes do it in cells first. We do it in animal models. Animal models could be mice, could be monkeys, but we do things before we ever get to people because we want to be sure we're safe. And so, all of that, it just takes time to make sure that we've done all those checks and balances. There are also problems, and I'll be trying to be very honest about this in terms of being able to get this to the brain. As I said, you could direct it straight into the brain. You could also have other ways of doing this into the spinal cord, but we want to get it into all cells in the brain. And the brain is very deep. And so when you think about this, how do we get it across all brain cells? How do we get it evenly? That's a challenge that we're working on. When we think about some of these conditions, they're neurodevelopmental conditions. In other words, there's development that's going on. So how do we make sure we get it in at the right time over a life course? And the answer is basically the earlier the better. But in many cases, there may be quite a big window. We don't know is the honest answer for all conditions, but earlier is better in terms of this. As I said, we also want to make sure that we don't have too much of an immune response. We want to make sure it doesn't go into the wrong cells. And in particular, with some of these things, we do want to be careful that we don't have off target effects. We don't have the gene or any of this going in the wrong place that might stir up cancer, might stimulate cells to grow that normally wouldn't be growing, because we do know with other gene therapy studies that has been an unintended side effect in the past. So with this, we're dealing with some of these practical issues. I'm definitely optimistic that in terms of going forward, this is one of these things, I call it a step function, because there are going to be enabling technologies. Then once certain people solve this, it could be for a completely different condition that's in your family. But once these technology problems are solved, all of a sudden, a huge number of conditions all at once benefit from this. And so important for us to be lined up at the starting line, ready to go with the scientists who are doing these breakthrough technologies to make it bigger genes, getting into the right part of the body, getting across all the different cell types that we need. And in some cases, if we need to re-administer it, having the ability to do that. So just to wrap up, to show you that we do already have 2 medications at the bottom that I'm showing you that are FDA approved. I was thrilled to be part of the spinal muscular atrophy studies, but there are many more that you can see that are sort of coming down the pipe. It's kind of what I was showing you with that big figure at the beginning, but now showing you just a few other conditions up close. The point that I want to make is that the farther they are towards the bottom of this table, that's kind of like the middle of the bullseye. And I hope you can see that there are things moving forward. And I am optimistic that we are going to get to the point of those trials, I hope within the next few years for some of these conditions. So we'll have time for questions later, but next up, Tim Yu is going to be talking to us about a different strategy using ASOs, or allele-specific oligonucleotides. And then Kim Goodspeed is going to talk to us about clinical trials and clinical trial readiness. See you later.
Good afternoon. It's a pleasure to be here. I'd like to start by thanking Wendy for the introduction, and all of you and the Simons Searchlight Committee for organizing this symposium and to create this opportunity for us to all discuss this topic. My name is Dr. Tim Yu. I'm a neurologist and geneticist at Boston Children's Hospital. I work in the Division of Genetics and Genomics, and I'll be sharing with you my thoughts on prospects for genetically targeted treatments for rare neurodevelopmental diseases. Now, by way of background, I lead a research group that has long focused on using genomics to study human brain development. We've used techniques of human genome sequencing to cast a better and more precise lens on the underpinnings of autism and other rare pediatric neurologic conditions. And it's been an incredible privilege over the last 15 years to live through and help push and advance this revolution in genome sequencing, which has hugely accelerated our ability to diagnose patients with rare diseases and to understand the fundamental mechanisms that are at play. With these successes in hand, however, we've been increasingly, as a field, and my laboratory in particular, focusing on the next challenge, which is that to take fundamental discoveries and understandings from neurobiology and genetics and to turn them into treatments, this still seems like it takes a long time. These statistics, compiled in 2014, capture how drug development has historically been slow and painstaking. Navigating the steps of making a new drug from proof of concept in the laboratory to clinical trials and FDA approval in the box on the left. This is something which in the past has required incredible investments of money and time with no guarantee of success at the end. Now, excitingly, however, many in the field believe that we're at the cusp of real change. New genetically targeted modalities hold out the promise of rapidly accelerating therapeutic development. What are we talking about? Genetically targeted medicine. So we're talking about things like gene therapy, like mRNA therapies made, for instance, famous by their deployment as vaccines for the current pandemic, antisense oligonucleotides, siRNAs, CRISPR genome editing. These are all examples of relatively new platforms for drug development that have the potential to bring remarkable modern efficiencies to the process of making drugs. And all of this is in contrast to traditional so-called small molecule drugs. And I'll spend a few moments explaining that contrast. By way of example, antisense oligonucleotides are going to be the genetically targeted modality that I'll discuss in this talk. They are the most mature example of what I'm going to describe to you as a modern, quote unquote, informational drug. More on that in a moment. Antisense oligonucleotides, or ASOs for short, are short snippets of synthetic molecules that are essentially mimics of naturally occurring DNA or RNA. They've been fantastically useful tools in basic science research labs for decades. And over this time, some 30 plus years, the field has gradually learned how to use them in clinical applications too. They are easy to manufacture. They have been chemically modified to have good properties like long-lasting stability and tight binding. And they can be administered as drugs via a variety of routes, intravenous, under the skin, by spinal tap, or even into the eye. And when they're administered in this way, they can be designed to home in on specific genetic targets, genes that cause disease, for example, or even, as we'll see, specific mutations in these genes. And they home in on these targets following very simple, predictable rules about Watson-Crick base pairing. A's pairs with T's, C's pair with G's, and so forth and so on. And depending on exactly how you design them, this binding can be exploited for multiple uses. They can, for instance, boost gene expression by altering patterns of gene splicing. Or in slightly different configurations, they can be used to shut down genes by targeting the RNA for those genes for destruction. This slide shows their use in the central nervous system. Antisense oligonucleotides have a distinct pharmacologic property and an advantageous property of being broadly taken up throughout the nervous system when you inject them via a spinal tap. And here we have a patient who is lying on his or her side and a spinal needle being introduced into the lower back. An injection of a small amount of antisense oligonucleotide into this lower spine results in levels of the ASO, shown in the vertical axis here, that are highest, of course, in the low spine and lumbar spinal cord. That's what SC stands for, where at the site of it, the administration, the needle was introduced. But it also distributes up through the spinal cord, up into the brainstem, and also into the cortex. And there, as it travels up the central nervous system, it is taken up broadly by all cells throughout the tissues involved. And so this is a slide showing microscopy images of neurons and glia from these regions of lumbar spinal cord, thoracic spinal cord, cervical cord, brainstem, and motor cortex. And in brown staining, this brown punctate staining that you're seeing here with the arrows pointing at highlighting particular cells, represents an antibody that's actually tagging the antisense oligonucleotide itself. And what this slide demonstrates is that multiple cells in this field, in fact, nearly all neurons in this field, have this brown staining within them, illustrating that they're taken up very, very broadly by neurons, as well as also in data I'm not showing you in glia too. So you can target these at the cellular level very effectively broadly throughout the brain and spinal cord. As I mentioned, the fact that these are synthetic nucleic acids, DNA or RNA, and the fact that they follow very simple rules for how they bind to their targets means that they are easily customizable. They have the virtue of being easily customizable for different genetic targets. Shown here are two antisense oligonucleotide drugs that I'll spend some time describing in the following slides that differ only in their sequence, the sequence of letters, A's, C's, G's, and T's. They have exactly the same chemistry, the same backbones, the same nucleotide modifications, but different orders of their bases, different ordered sequences. And the top one in green targets a gene called SMN1 in the human genome, and the bottom one in blue targets a gene called CLN7. And by simply altering these sequences, we can repurpose these drugs for a variety of different genetic targets and make them do different things. Perhaps the best example of an antisense oligonucleotide drug is one that was recently designed for spinal muscular atrophy, or SMA. Many of you may know this condition and this drug. It's sort of a textbook example at this point, now 4 years after its introduction. But SMA is a genetic disease that's caused by loss of SMN1, a survival factor for motor neurons. And in this condition, babies are born with very, very low muscle tone. And tragically, from this early point, they grow progressively weaker, such that they suffer untreated from respiratory failure by age 2 of life. Now, one interesting biological tidbit about SMA is that our genomes actually encode a backup copy of the SMN1 gene. Again, SMN1 is the gene which is mutated in SMA. And it turns out that we have a gene called SMN2, which is in our genomes, and it's 99% identical to SMN1. But unfortunately, it's been rendered inactive by an evolutionarily acquired C to T mutation. The consequence of this evolutionarily acquired mutation is that it alters SMN2 splicing such that it skips a critical exon. This seventh exon, which is X'd out with the red X there, is missing from the SMN2 RNA. And the result is that this RNA now encodes a non-functional protein, a non-functional SMN protein, such that this backup copy is essentially wasted. Now, many of you may know that 4 years ago, there was a remarkable new drug that came out in phase 3 clinical trials as being really amazingly beneficial for patients with SMA. And that drug is called nusinersen. Nusinersen is an antisense oligonucleotide drug. Its sequence is here, and it's an 18 nucleotide synthetic RNA, which homes in on the SMN2 gene. And here it is in this green half ladder here. And it homes in on the SMN2 gene, in particular in this region where there has been this evolutionarily acquired mutation. And it essentially masks the mutation. It hides the mutation, allowing the cell to actually splice the SMN2 gene product properly. And it results in production of a functional SMN protein. And back in 2017, at the very end of 2017, phase 2-3 trials were being conducted that showed that the survival rate of infants with SMA was hugely enhanced if you simply dose them by spinal tap with this drug, nusinersen, just 3 times per year. And this first remarkable result that was published eventually the following year in early 2018 has been followed up by 3 or 4 years of really remarkable clinical successes where this is now the mainstay for SMA therapy. And these infants are now thriving with this splice-correcting antisense oligonucleotide drug. Back in 2017, we also even demonstrated that you can use this type of strategy, as first demonstrated for nusinersen, to develop drugs not just for rare genetic diseases like SMA, but even for individuals. In January of 2017, my lab met a young girl named Mila Makovich, who was 6 years old at the time and suffered from vision loss and neurologic decline due to a fatal neurodegenerative condition called Batten disease. Batten disease, like SMA, is a recessive condition caused by mutations that disable a gene that's critically responsible for neuronal survival. And in the case of Mila, her particular mutation was an unusual one. Her normal CLN7 gene, or a normal CLN7 gene, is shown up on the top. Her copy of the CLN7 gene included a misplaced segment of genetic code that created a new splice site in the CLN7 sequence. This new splice site hijacked the normal assembly of this gene such that exon 6 no longer connected to exon 7, but it now connected to this abnormal new and pathogenic splice site. And this, our finding of this mutation, we recognized created an opportunity to actually silence this mutation using a custom designed antisense oligonucleotide, one that we designed to home in on this region and essentially hide it from the cell such that normal splicing could be restored. And this story, which has been widely reported in the literature and in the scientific media and the lay press, allowed us to actually go from a patient referral in January 2017 to developing an individualized medicine for her in just 1 year's time. This story and the success of nusinersen and the success of early successes of several other promising drugs to follow highlight the advantages of antisense oligonucleotides as a representative of a new class of drugs that can be really thought of as therapeutic platforms. That these are classes of drugs that are rapidly customizable, that are simple and inexpensive to manufacture, Antisense oligonucleotides in particular are especially easy to deliver because they can be injected just by dissolving them in a salt solution and injecting them into the spinal cord. And that our experience or our early experiences with antisense oligonucleotides indicate that they have a remarkable potential with a growing safety and efficacy record for a number of different diseases. And the promise of these rapidly customizable platforms is that this type of platform is what we've all recognized as to be ideal or even absolutely necessary for tackling conditions, this says tackling drugs, but it really should say tackling diseases that have been previously thought by industry to be too rare for commercial investment. That the rapidity by which you can design new drugs using these platforms opens the door to rarer and rarer conditions. Now, our work on developing an individualized drug for a patient with Batten disease has been followed up by several other examples of applying antisense oligonucleotides for exceedingly rare and ultra-rare conditions. One example is J-Suffusin. J-Suffusin is an antisense oligonucleotide drug that was advanced by Neil Schneider of Columbia University in collaboration with folks shown here. And this was a customized antisense oligonucleotide drug that was deployed for a young woman with an ultra-rare form of ALS, an ultra-aggressive and rare form of ALS associated with mutations in the FUS gene. And another example that followed just earlier this year of using an antisense oligonucleotide drug for a rare genetic condition. It was advanced by Bob Brown and Jonathan Watts, who developed a drug that they named afanersen for another genetic form of ALS, this one associated with mutations in the gene C9orf72. And in this manuscript that was published in a preprint in February of this year, they described the accelerated development of an ASO, followed quickly by first-in-human pilot studies that show promise for the ability of this antisense oligonucleotide to reduce levels of a toxic mutant C9orf72 gene, which is present and causing disease in patients with this condition. As one further example, we at Boston Children's have followed up our work for Batten disease to demonstrate the use of an antisense oligonucleotide to treat a young baby who was accidentally diagnosed with a fatal genetic disorder at birth. This is a young girl born in California whose newborn screening raised the concern for an immunodeficiency. However, that turned out to be a red herring. Genetic testing subsequently showed that she had the unfortunately progressive and fatal neurodegenerative condition named ataxia-telangiectasia. This is a condition in which there's progressive loss of motor coordination due to degeneration of the cerebellum, and it's caused by mutations in the ATM gene. However, because she was diagnosed so early and had a precise genetic diagnosis, we were able to discover that one of her mutations appeared ASO amenable and created a new splice site, allowing us to develop an antisense oligonucleotide for her in just about a year and a half's time and begin treating her in January of 2020. So all of this activity, the use of ASOs for even ultra-rare and even individualized indications, is of course paralleled by traditional ASO activity, developing drugs under more conventional approaches for larger diseases. And shown here, this is a slide summarizing ASO drugs that have been FDA approved now for spinal muscular atrophy, but also systemic conditions like TTR amyloidosis or familial hyperchylomicronemia syndrome. But there are also a number of clinical trials of ASOs for neurologic indications that are of interest to this group, including ALS, Huntington's disease, and then neurodevelopmental disorders like Angelman syndrome and Dravet syndrome. The ASO for Angelman syndrome bears more discussion. This is an ASO that was advanced by Scott Dindo, Allison Barrett, Paula Evans at Texas A&M University by the parent-led biotech company Genetics. And Angelman syndrome, as some of you may recall, is a condition in which there are deficiencies in the UBE3A gene that lead to an autism-like presentation. And in normal individuals, the UBE3A gene is activated and on and present. It turns out that in neurotypical individuals that it's only mom's copy of the UBE3A gene, which is actually active. And dad's copy is actually silenced. It's actually sitting sort of in reserve, and it's silenced by a cellular mechanism that actually suppresses dad's copy. And that cellular mechanism involves a UBE3A antisense gene called UBE3A-AS. In individuals with Angelman syndrome, mom's copy of UBE3A is unfortunately disabled, usually by deletion, but sometimes by point mutation. And dad's copy is present and usually normal, but unfortunately still silenced by this cellular mechanism. The ASO strategy that Scott, Allison, and Paula advanced for Angelman syndrome involves using an ASO that is designed to silence the cellular machinery that normally shuts down dad's copy of UBE3A. And so designing an ASO against this UBE3A-AS gene, one can actually block its activity and then reactivate and turn on dad's copy of the UBE3A gene, allowing UBE3A protein to be expressed once again. And in very interesting early reports, early phase 1-2 data reported by the genetics group, which had also paired up with Ultragenyx, illustrated that they enrolled 5 patients who received escalating doses of GTX-102, their antisense oligonucleotide, for somewhere between 4 and 5 months. And 5 out of 5 individuals reported significant neurologic improvements using something called the Clinical Global Impression of Improvement, AS scale. They were scored as much to very much improved, with their specific improvements in the domains of expressive and receptive language, gross and fine motor skills, and EEG metrics. And this finding itself, which I'd like to highlight, shows that the concept that many of us have long believed in, that there's neuroplasticity that's latent and triggerable using therapeutic pharmacologic approaches, appears to be true in Angelman syndrome. And granted, this is only the first 5 patients, but this is very, very promising with respect to that concept. Now, an important caveat here is that there was a pitfall in this early investigational trial, which is that those 5 individuals actually developed transient leg weakness, which led to this trial being put on hold. So I think this slide shows in a balanced way both the glass half full but glass half empty consequences of the early experiences here. There are some pitfalls to be navigated, but if we can do it right, going after these genetically caused neurodevelopmental conditions shows significant promise. And where does this leave us? Well, I'd like to just close by just highlighting the fact that the reasons for optimism in the space are that with chemistries and drug development approaches like antisense oligonucleotides, we are beginning to see the emergence of what we can consider our true therapeutic platforms. Antisense oligos, AAV gene therapy, CRISPR genome editing, these are all tools that if we can get them to work just right, we can use them in flexible ways to make drugs for many different kinds of diseases, for many different genetic targets. And that we can take this challenge, which has been the number of genetic diseases that there are for us to develop treatments for, and we can begin to chart paths towards surmounting this previously daunting challenge. And that through charting these paths, one gene or even one mutation at a time, we can begin to plot our attack on the face of El Capitan, so to speak, and make our way up and hopefully learn from these experiences to accelerate drug development for many different genetic forms of autism and other diseases. That's my closing slide. I'd like to stop there, and thank you for your attention, and look forward to discussing these ideas with you further.
Okay, so I will get started. So welcome everybody today to the Q&A for genetic therapies and neurodevelopmental conditions. I'm your moderator for the session. My name is Misha Kawanda. I'm the outreach manager at Simon Searchlight, and I'm joined today by our two speakers, Dr. Timothy Yu and Dr. Wendy Chung. Thank you both for your very interesting and informative presentations. For everybody listening in, you'll be able to see and hear us, but we won't be able to see and hear you. We highly ask that you engage in the session and ask questions in the Q&A box at the bottom of your screen. Please remember to avoid including personal health information in your questions just for your own privacy. We apologize in advance if we don't get to all your questions. We may get a lot of questions for this session, but we'll try to cover as much ground as possible. And since there's so many genetic conditions represented today, we might have difficulty answering very specific questions to your condition. But that being said, we will start with our very first question. So I would like to ask, I'll start with Dr. Chung. Where can I find out more information about ongoing genetic therapies for my genetic condition?
So there's a great resource that the federal government has, something called clinicaltrials.gov, G-O-V, clinicaltrials.gov. That's actually a great resource, not just for gene therapies, but it includes all active clinical trials in the United States. You can type in, when you go there, type in your condition, and that should then give you a list of all of those research studies, clinical trials, gene therapy studies, anything in the United States. It's color coded, and sorry if anyone's colorblind, but green are active studies that are open and enrolling, and red are ones that are already closed, but you can get a sense then of what companies are involved. You can get a sense of what they're doing, who's invited, what sites are around the country. So you actually can get a lot of detail very quickly. So clinicaltrials.gov.
Thank you. Our next question is, once someone gets gene therapy or genetic therapies, do these effects last forever? So how long do they really last? And so I'll start with Dr. Yu.
Yeah, that's a really good question. So the answer is that it depends on the modality. So there are different types of gene therapies. And in the most commonly referred to version of gene therapy, a gene replacement, where a virus is used to deliver a good copy of a gene that might be missing in a patient. The hope is that that is a forever therapy, that the virus will bring the gene to the patient, that it will begin to do its job and express itself. And the hope is that that will be a durable effect that could last the lifetime of the patient. In reality, however, we don't yet know if that promise will actually pay off. And there are various reasons why a gene therapy effect could end up being shorter than that. If the body's immune system were to, and Wendy alluded to this, were to begin to generate a reaction against the gene product that was being made. There are a variety of different reasons why it might fall short of that, but that's the concept. Other types of genetically targeted interventions, for instance, the ASOs that I referred to, are long-lasting, but not forever therapies. If you inject an ASO, for instance, into a patient for, say, SMA, that effect will last long enough that you can go for weeks and weeks and weeks without having to come back to the doctor. But you will have to go back to the doctor 4 times a year to get that therapy. So it lasts on the order of months, but not forever. And so these are considerations that differ a little bit depending on the modality. So the answer is it depends to a certain extent.
Thank you. Dr. Chung, if there's anything you'd like to add?
No, I think the main thing is, Dr. Yu said, is that we haven't been at this for decades. And so we still are at the very, very earliest stages where some people have had a few years into this to know that that is a durable or a long lasting response. So I think we're all sort of just at the frontier in terms of what this is. And with that, we're watching closely.
Okay, thank you. Along the same topic, why are viruses commonly used in gene therapy, and do all gene therapies require viruses? So Dr. Chung, we'll start with you.
Sure. So viruses are good at infecting us. We know this all too well right now with the coronavirus flitting about. And so they're very good, and we co-opt that. We use that ability for the viruses to infect the cells, but instead of for sickness, for health in this particular case. Again, I said this before, but we gut these viruses so that they're not doing the things that they usually do. We're really co-opting their machinery as a way of being able to be very efficient, being very effective, and hopefully by getting all the cells, or at least as many of the cells as we're trying to target, hopefully being able to have that durable or that long-lasting response. It's not to say it's the only method of delivery. And again, I think what Dr. Yu was talking about doesn't require the virus. There are other things that we use the same technology for. Some of us that got a Moderna or Pfizer vaccine, those same delivery mechanisms. So there's more than one way to skin a cat, so to speak. And I fully anticipate there are going to be novel developments with other things down the road, but it is very common to co-opt these viruses because they're so good at infecting us.
And Dr. Yu, if there's anything you would like to add as well.
No, actually, I think what Dr. Chung covered was perfect.
Thank you. So a question came in about, is it necessary to understand the molecular mechanism of a gene in the human body in order to develop therapeutic interventions? So we'll ask this from the perspective of gene therapy or genetic therapy interventions. Dr. Yu.
That's a really good and important question. And the answer is a little bit nuanced. So one needs to know a little bit, it's important to know a little bit about the gene for sure. Because there are a couple of critical questions. If you're contemplating trying to make a gene therapy, there are a couple of critical questions that you have to address. One is that you have to be convinced that a given genetic syndrome may be caused by lots of different mutations. And the question is, what do those mutations do? Dr. Chung alluded to this in the intro. Sometimes those mutations will disable the gene and render the gene non-functional. And so the fundamental problem is that the gene is not working. And therefore, what you need to do is to make more of it. There are other mutations that have the opposite effect. They actually might make a gene hyperactive, or they might make it poisonous. And in that case, adding more of the gene back might actually be exactly the wrong thing to do. So you do have to know that type of basic elemental information about the mechanism of the gene and the mutations that are causing this condition. You also have to know how much of the gene is required for a cell to be happy, for a brain to be happy, for a patient to see some clinical benefit. And there are some tricky situations where too little is bad, but too much is bad as well. And so you have to be cautious of those types of mechanistic wrinkles as you're trying to develop a gene therapy. So that's the level of information that you do need to have as you're trying to develop a gene therapy strategy. Whether or not that gene has a specific role in one particular part of the cell, its exact biochemical function down to the atom, that arguably is not absolutely necessary to know to develop a strategy. But those basic questions you have to answer.
Okay, thank you. This makes the next question kind of form along where we're thinking about researching this, exploring this, and getting researchers interested. So how do patients, participants get researchers interested in developing genetic therapies for their rare developmental condition? Dr. Chung.
This is a really important question, and I know sometimes families with ultra rare conditions feel frustrated. They feel alone, and it's hard to be able to get enough attention. So it's band together. It's a numbers game. And in terms of researchers, it's making their lives easy. So allowing them, facilitating, giving them the tools to do, wrap their brains around it and to make it easy peasy lemon squeezy for them to do this. So what do I mean that you can do specifically to do that? And I know I sound like a broken broken record, but if you give your cells, if you give a part of yourself, it doesn't have to be much, but if you give a blood sample that whether it's Simon Searchlight or someone else can make a cell line from that, one of these induced pluripotential stem cells, there are all sorts of experiments they can do to try things out, see what might work, understand those mechanisms that people were asking about. How does this gene work? How does this particular genetic variant work? All of that preclinical studies, all of those preclinical studies, incredibly important in terms of figuring out before we ever put something in humans, whether it will work. To be explicit on this, numbers matter. So I'll give you an example that I'm sure that both Dr. Yu and I have the same experience. People will come to us and try and get some sense. And I'll be very blunt. It's, what's the market for this? Are we talking about 2 people in the world? Are we talking about 2,000? Are we talking about 20,000? And I realize for some of our families represented, we don't have numbers like 20,000 yet. It's not that they're not out there. I want to underscore that, right? They are out there, I'm fully convinced. They just don't yet know their diagnosis. So passing, and you can easily do this. You are in communities with other individuals who may have similar symptoms, your friends, your acquaintances, get the word out in terms of being able to know what club you're in is the first step. Knowing what first step for you personally, and also a step for the community to make sure our numbers are heard, that people understand exactly what the burden is for each of these conditions. So the combination of doing that, understanding, and so some of you have seen our voice of the community, that we're trying to hear from you. We want to understand. We want your voice to be heard and amplified to researchers, to industry, to pharmaceutical companies, whoever is willing to listen in terms of hear what our concerns are, hear what our priorities are, hear our numbers, hear us roar. Let's put this all together. So by doing that and making it easy, I think bright minds will just aggregate, come to this, if nothing else, just because they hopefully want to do good for people, but also because they can apply their talents and feel good about applying those talents.
Thank you. Yes, Dr. Yu, so a similar question. So how can a parent find a specialist available to experiment with ASO therapy for their child's genetic condition?
Yeah, it's a very good question, and it's a tricky one. This is a very early stage in the field. There are some really exciting developments, and I hope I conveyed that in my talk. And at the same time, it's also cutting, arguably bleeding edge, and so there are risks involved as well. So I think, as Wendy said, organizing and self-organizing to help make it so that when you do reach out to the researcher, that there is as much you have as much information available to that researcher to be able to easily digest what the community's needs are, what the size of the community is, and all of the availability of tissue samples and things that would be necessary to actually do the work. I think that's all incredibly helpful. Right now, there are not easy answers. There's not a ASOresearchers.gov resource like the way there is a clinicaltrials.org resource. But there are a number of places that are standing up to begin to try and solve that problem. Patient communities, academic medical centers, and foundations. One that I'll point out is the NLORM Foundation. The NLORM Foundation is a foundation, a charitable foundation that was launched by Ionis, the company that made Spinraza or nusinersen. And they were inspired to create and to be one of the points of contact for families with ultra rare conditions. And I encourage you to look them up. I can perhaps, I can point you to their website, which is simply nlorm.org. And you can learn about them and their mission. But in addition to that, however, there are other sort of grassroots efforts to try and help families seek out the scientific context that they need. That I'll try and remember a couple of key efforts that maybe I can circulate to you all for sharing with the community afterwards, but they're escaping me at the moment.
Thank you. And so keep the questions coming in, everybody. We have lots of great questions coming in. Dr. Chung, when you mentioned with some of these conditions being so rare and bringing the resources and gathering as a community, in general, how many years away can the communities expect potential therapies? I know this is a really difficult question to answer. 10 years, 20 years, realistic expectations for the families.
Right. So I will admit it is a very hard prediction because I do think there are breakthrough technologies. I think that once certain critical questions are solved, or then I think, as I was alluding to, many people get to move forward. Within this, I do think, as Dr. Yu was suggesting, all the oligonucleotides, I think, are actually both safe and in some cases quite effective. And so I think there are issues that are more regulatory issues, in my opinion, with the FDA in terms of thinking about how to apply this on scale, how to make sure that, this isn't for every one of these conditions a major enterprise. Can we sort of bundle them in some ways in terms of thinking about safety data, toxicity data, and be able to minimize the burden both in terms of manufacturing and regulatory issues. And I do think Dr. Yu is a leader in terms of thinking about this and working with the FDA for this, and that's part of why we have him here. In the same, the next phase of these things in terms of thinking about now genetic therapies, so whether it's AAV or other lentiviruses or gene editing or CRISPR-A or, any of these different technologies, we're farther back in terms of that. We're not at the point of being able to just rinse and repeat and scale this and be able to have all adeno-associated viruses sort of incorporated. We're just earlier in that. So I don't think for that vision, I don't think that's a 2-year timeline. So we're not as close in terms of that. Is it 20 years? I hope not. And then we're somewhere in between that, right? And so I think that becomes very difficult to know, is that going to be 5 years, 10 years, 15 years? But I do think they're going to come in bunches. So I think they're going to come in bunches in terms of where you need to get in the body, when you need to get in the body, and in terms of this, exactly the mechanism we've been talking about. So do you need to add back? Do you need to take out? Do you need to literally precisely edit? And I think those are tricky questions. I will say just some of the other issues is that for some of the families represented here, where it's not even known to be a single gene, where there might be a copy number variant or a segment of DNA, step one is also to identify what the genes within those segments are the critical genes. It's probably not the case that we're going to have to add back all of those genes, but identifying what are the 1, 2, 3, 4, something like that number of genes that are critical. So there's kind of a step before getting to the starting line for those groups as well.
Okay, thank you.
I just wanted to say, I think that Dr. Chung's phrase "coming in bunches" is a really excellent way to put it. It also illustrates how difficult it is to project out timelines, because what one sees is certain breakthrough technologies then, which are difficult to predict exactly when they arrive, will then often have a cascade effect of accelerating things very, very quickly for a period of time. One extra dimension I'll add on top of what Dr. Chung said is that perhaps one helpful way to look at it, in terms of finding a commercial partner to push and develop and then sustain a genetic therapy for a rare condition. I think that one practical framing that's helpful is that I think there are many industry who are actively looking for conditions, say a population of 1,000 or more individuals, and that there is a reasonably clear playbook for approaching folks in industry and with coupling the right science with the right commercialization partners. There's a relatively clear playbook for advancing those relatively quickly in the matter of a few years. I just want to acknowledge, though, that it's for conditions that are sub 1,000, where initial new creative approaches towards the financing of these efforts are going to be required. And whether it's actually going to be a commercial vehicle, which has been the traditional way, or whether nonprofits will step up or academics will step up to advance investigational therapies for those, that's an area of a lot of active innovation right now. And I think that it's an area where family and patient activism can actually do a lot to influence the direction. So I just want to encourage people to think about that. If you recognize the problem, then you can come together and perhaps come up with a creative solution for it. So in a way, I just want to lay that charge down to folks to think about that challenge.
Let me add one more thing to what Dr. Yu is mentioning, is that even though the numbers might be small, your voices can be mighty. And so if you think about how to amplify your voice, and some of you have already figured this out, I will say that right now in Congress, it's actually to me a very critical time. There was some congressional funding for something called 21st Century Cures. And there are considerations right now in terms of, we call it Cures 2.0, just for short, but thinking about what that next phase will be. And rare diseases and genomic medicine sort of as themes are actually under strong consideration right now. And so I know it sounds like a cliche, but I've actually done it and it works. So call your congressman, call your senator, let your voice be heard, gather together and all of you do it. And if you do, and especially they love to understand the story. It's not just, you know, sort of an anonymous email, but tell them your story. Let them know, send pictures of your kids, you know, let them fall in love with you the way we've fallen in love with many of your families. And it really becomes meaningful and your voice gets amplified. But it is critical to think about doing that now because, you know, in terms of doing this opportunity won't come up, you know, every 6 months. This is going to be a big commitment and this will be the big commitment. And so legislatively, you want to make sure that rare genetic diseases, rare neurogenetic conditions specifically are targeted.
I really appreciate that both of you are touching upon some questions that are coming in around what can we do now. So I think Dr. Chung and Dr. Yu have really highlighted some important pieces for what can be done now. And on a tangent or on a little bit of a different note, once a person gets a genetic therapy, how long do you know, how long does it take to know if it's working? So we'll start with Dr. Yu.
That's a really good question. And one of the really critical questions that we all think about, even before we start to actually conceptualize a therapeutic strategy, is that how do you know it's working, right? And there are some conditions, I think that the clearest answer comes for conditions that might be associated with something that we can expect can change rapidly. For instance, seizures. Patients in the patient example that I led with in my talk, I described a condition called Batten disease in which one of the prominent features is multiple seizures per day. And that becomes a very helpful and a potentially dynamic way of seeing on a day-to-day basis if the treatment you're having is having some effect. Not perfect, but there are things that can make seizures go up and down, but it is something that you can use to help guide you and giving you relatively quick answers in the time scale of sometimes even weeks and months. The case of seizures might be there or they might not. And there may be actually mainly other outcomes that we really care about, like the ability of our children to communicate, the ability of our children to walk, the ability of our children to take care of themselves, or even to sleep through the night. And this is an area where I think you'll be hearing more about this later today, where these sorts of measures, to be frank, are areas where we're still learning how best to capture them. And we can definitely anticipate that they will take longer to figure out, that they may take not weeks to months, but months to sometimes a year or two for us to see meaningful change. But I think that we're learning more about these every single day. I referenced an Angelman trial that lasted only 4 months. But during that time, I think we were the investigators were, and we as a field were surprised that meaningful changes were at least being reported in the small numbers that I mentioned already in just a matter of a few months. So I think it's a really active area and lots more to be said about that in the future.
Thank you. We have a few more minutes for this session. There's some great questions coming in. Dr. Chung, this interesting question is about, is it important to get whole exome, whole genome sequencing in assisting to develop a treatment program? So a lot of our families, a lot of the conditions, they might have had just a panel test. So when you're thinking about gene therapy, genetic therapies, is this something that will be important for the kiddos?
So I think the entry, if you will, your ticket to get in the door is having the correct diagnosis. And that is one of the reasons why we painfully ask in Simon Searchlight that we can see your genetic test report. We want to make sure you're in the right chapter, in the right club, and that you're sort of lined up for the right race. That is the reason we do it. Doesn't happen very often, but every once in a while, there's someone who's lined up sort of three lanes over, and we need to adjust them. It is pretty rare for individuals to have a dual diagnosis, that is to have two different genetic diagnoses. I do see it. I see a lot of patients, so I think that's why I see it. And in general, what sort of comes to mind is when I see someone who seems to be outside the range of what I usually see for that condition. That's my tip off in terms of someone who may have had a panel gene test and thought they had the right diagnosis. And I say, you know, you've got something else that feels like it's not part of this usual condition. Let me now broaden out and look for something that might be an exome, a genome, but some additional testing to see if there's something else going on. And occasionally I will find that if I have a high clinical suspicion. Most people who've had a panel gene test, especially when we know these are de novo or new genetic changes in the child and not present in the parent, and clearly categorized as what we call pathogenic, don't need to do additional testing. If it is required, I anticipate that the companies or the people sponsoring these trials will actually pay for that testing. So if it becomes a requirement in terms of inclusion in the study, at least in my experience, many of the laboratories will bundle that and include that within the screening visit or the initial evaluation to see if you're eligible. So I wouldn't worry about that unless you and your doctor are suspicious that it doesn't feel like you or your child quite fit into what you are expecting. If that's the case, speak up.
Thank you. And Dr. Chung, there's actually a clarification question. You mentioned that Congress is interested in something called, is it 21st Century Cures?
So 21st Century Cures was the initial legislation, and this is, we now think of sort of part 2 of that, being able to continue and extend the funding for the 21st Century Cures. And if you're writing your congressman, you can write Cures 2.0. That's an easy way to think about it. They'll know what you mean.
Okay, thank you so much. And then we just have one last quick question we'll ask Dr. Yu. If someone gets genetically, if gene therapy works and someone is functioning and they're genetically, their somatic cells are functionally corrected, would that enable that person to have healthy children or children without a certain syndrome?
That's a really good question. And the way in which we are using gene therapies at the moment, we are specifically avoiding creating changes that then are transmitted to the next generation. So the answer is that that whatever effects and benefits that we see through the treatments that we provide will unfortunately not be passed along to the next generation. I think that that's not us, that we're not quite ready for yet, as Wendy alluded to. But it's a great question. And then I would encourage folks to speak to their geneticists and genetic counselors to figure out what the risks would be given that situation.
Thank you so much. Thank you everyone who joined our Q&A today. Unfortunately, we're going to have to stop this session. There's going to be a brief break for 10 minutes before we have Dr. Kimberly Goodspeed's presentations. But thank you, Dr. Yu and Dr. Chung, for taking the time to answer our questions. We really appreciate it. And also, we just want to throw out a Simon Searchlight. This is one way that everyone can band together. So we really appreciate everyone that was able to join today and everyone who's participating, improving, and participating in the genetic registry that we have. Thank you so much.
Thank you so much, Misha.